Welcome to the presentation for Module 7 for Fall 2016. This presentation will discuss the disease processes of Guillain-Barre and Myasthenia Gravis. These are disorders of the peripheral nervous system. Again, we will discuss the pathophysiology, nursing care, treatment, diagnosis, and education regarding these disease processes of the peripheral nervous system. It is often related to some kind of virus or infection where there is a production of abnormal antibodies that settle on the motor neuron, causing it to dysfunction. It's typically self-limiting over days, or in some cases, there's some permanent residuals such as weakness. But for the most part, it does resolve, and it's depending on the patient as to how long that takes. Guillain-Barre is an uncommon disorder. It affects males slightly more than females. It is thought to be associated with an Epstein-Barr virus, which is mono, cytomegalovirus infections. There's a bacterial infection known as Campylobacter jejuni, which is thought to be associated with it. In some incidences, it has been associated with vaccines, but there is thought to be some association, but the evidence thus far is weak. However, if you've ever noticed on your questionnaire before you get your flu vaccine, they'll ask you if you've ever experienced Epstein-Barre Syndrome, because it's thought to have some relationship to the flu vaccine. So again, it's related to a result of immune-mediated pathology. The antibodies attack the myelin sheath that surrounds the axons of the peripheral nerves, which causes temporary damage and demyelination. There's a table in your book, the key features of Guillain-Barre syndrome. It's important to look at that. And I have a couple of pictures in the next few slides about how the process occurs and how it ascends up the nerve tract. There is no single common lab finding that will confirm the diagnosis of Guillain-Barre. However, a lumbar puncture to obtain cerebral spinal fluid may be done to determine if there's an increase in cerebrospinal protein levels that occurs in inflammatory processes. That would be indicative and go along with the differential diagnosis of Guillain-Barre. Sometimes, though, the high protein levels may not occur right away. The cerebrospinal might also have high white blood cells. A patient's blood draw, just a serum blood, would also possibly show an increase in white blood cells to indicate some type of infection. Make sure you understand the care of a patient undergoing a lumbar puncture. Make sure you explain the process to them, help them stay still in a fetal position during the obtaining of the cerebrospinal fluid. They do take a needle in between the lumbar to obtain the cerebrospinal fluid, so the patient needs to lay still. You monitor their vital signs and their neurologic status during the procedure and after the procedure. They do have to typically remain flat for a while post-procedure, so you'll have to educate them on that and why they have to. That decreases the incidence that they might have a fluid leak. Monitor for complications, anything indicating that they have a change in their neurological status. Watch the site for leakage and notify the physician in the incidents that the leakage, you do suspect a leakage. Another test that may be done is an EMG. It's used to identify nerve and muscle disorders as well as spinal cord disease. It tests nerve function. So that's another kind of test that may show some abnormal findings that would go along with the differential diagnosis of Guillain-Barre syndrome. This picture is just a visual of the ascending way that the paralysis occurs. It typically starts in the lower extremities and moves its way up, with weakness, ataxia, bilateral paresthesia progressing to paralysis. The important thing to remember that there's this ventilator here because it can ascend all the way up to where it affects your thoracic muscles. The patient is no longer able to breathe on their own. This is something that we always, in somebody who has a diagnosis with Guillain-Barre Syndrome, we have to be on the lookout to determine whether they have lost the ability to breathe on their own. So we have to be ready at all times. So if you admit somebody with Guillain-Barre, you want to make sure that you have oxygen suction equipment available at all times in the room in case this progresses over time up to their thoracic muscles. There are several types of Guillain-Barre. Descending can start in the brain and work its way down. It's very, very, very rare. The most common type is the ascending type of Guillain-Barre. Again, just reviewing the diagnostic testing, lumbar puncture will be done to determine whether there's any protein in the cerebral spinal fluid. Make sure you review the care of a patient undergoing a lumbar puncture. Priority nursing care, like I said, is that respiratory care, making sure that we are on the lookout for any airway compromise, because people with Guillain-Barre syndrome are at risk due to the fact that it can affect their thoracic muscles and their ability to breathe. This can be a life-threatening situation in the event that the patient is not diagnosed properly and monitored properly. It's important to remember that it is typically self-limiting. A patient can be sick for a period of time, and then the demyelinization, the inflammation will resolve, and the patient should return to normal. However, sometimes there could be some residual due to the decreased mobility for a certain period of time, and you guys know that when someone has an illness that causes a decreased mobility, they often have weakness and muscle atrophy secondary to the immobility. So oftentimes, even after the infectious process resolves, the patient will have to go to like physical therapy and just sort of kind of get their strength back, really. And that can go on, that can be months. It depends on the patient's status when the disease process occurred. So if they were really, really healthy when it started, they typically bounce back quicker. And, as opposed to somebody who maybe already had some illnesses and poor motor ability in the beginning, they won't bounce back as quickly. It's important to help the family understand that this is not a death sentence. Guillain-Barre is not. It's typically self-limiting, and the patient typically can recover from this. So it's important during the time that the patient is undergoing the symptoms of the paralysis that we also monitor their pain, help them with communication and emotional. This could be a young person, and actually the patients that I've taken care of with Guillain-Barre were very young, and this was really difficult for them to all of a sudden be paralyzed. And so communication and emotional stability is something that it's important that you kind of help support. Nutritional, of course, if the patient is unable to take in their own nutrition, we will support them through parenteral nutrition, such as maybe feeding them through an IV, or perhaps maybe getting an EG tube and feeding them that way. We have to support their nutrition and support them through this infectious process. Treatment for Guillain-Barre can be plasmapheresis. I think we've talked about plasmapheresis before in treatment of some other disorders, and basically it's kind of like a dialysis, and it's where we take out the blood and we remove the antibodies that are causing the patient's symptoms, and then return the blood back to the patient. It typically works better if we start plasmapheresis within several days after the onset of illness. Nursing interventions for the patients undergoing plasmapheresis include providing information and reassurance. They typically need to be weighed before and after the procedure. Making sure we care for the site, the access site, which is typically like a dialysis site. Make sure you check for patency by checking for a bruit or a thrill every 2 to 4 hours. And observe the access site for bleeding or any kind of clotting. There is a good chart in your book called and labeled Preventing and Managing Complications of Plasmapheresis It's important to review that to make sure you're prepared to manage the care of a patient undergoing plasmapheresis that could be related to their Guillain-Barre. Managing a patient with Guillain-Barre, of course, that cardiac dysfunction, a lot of it's the ABCs, maintaining their airway, their cardiac function, and circulation, improving mobility. Passive range of motion is very important, in having physical therapy come in and work with the patient's muscles to prevent increased atrophy. Even though they're paralyzed, we could do some passive range of motion to help maintain some of their muscle strength. They do have some degree of pain due to the demyelinization of their nervous system. They could have hyperesthesia, which is extreme sensitivity to touch, deep muscle aches and muscle stiffness. The typical pain experience is severe and requires opioids. A lot of times it's worse at night, and so we need to make sure that we monitor it, assess it, and treat it effectively. Gabapentin is a medication. It's known as Neurontin. That is, it's also a anti-epileptic medication, but it can help decrease nerve pain that people have. It's often used for diabetic neuropathy, but it also can be used in this case, again, for that neuro pain. Make sure you don't forget that the patient and the family can be devastated. This is a young man who has a family, all of a sudden is in the hospital for maybe 3-4 months due to paralysis, can't work, loss of income for the family, things like that. It's important to support the family and provide support in these incidences. Help them find community resources. Also, after they're discharged, because they might need to follow up with physical therapy, and it might help them to talk to support groups to help them kind of work through and process the illnesses. Okay, moving on to the next disease process called myasthenia gravis. Myasthenia gravis is a disorder of the neuromuscular junction. It's thought to be autoimmune. It's where antibody occupies the muscle receptor for acetylcholine. If you remember, acetylcholine is a neurotransmitter in the nervous system that helps to spread impulses throughout the neurons in the nervous system. This autoimmune process causes antibodies to be attached to the acetylcholine receptors. As a result, nerve impulses are reduced at the neuromuscular junction, and the nerve impulses do not result in muscle contraction. The symptoms of myasthenia gravis are usually muscle fatigue associated with use. Typically affects smaller muscles, which have more acetylcholine receptors than larger muscles. Therefore, eye movement and speech are most commonly affected. The symptoms usually decrease with rest. As with most autoimmune disorders, the symptoms present in each patient a bit differently. There's different classifications of myasthenia gravis, and they're classified as to where their symptoms are. So class 1 is just ocular muscle weakness, and then class 2 goes on to mild weakness affecting other than ocular muscles. All the way down to class 4 is severe weakness affecting other than ocular muscles. May also have ocular muscle weakness of any severity. So it just varies, like any other autoimmune disorder, from patient to patient. There is a class 5 of myasthenia gravis, which indicates that the patient may have need for intubation because they have severe weakness in their respiratory muscles, so they will require being ventilated. So again, it's important to, if you are admitting a patient with myasthenia gravis, to determine how severe their symptoms are. If they have more severity, if they have muscles more than their ocular muscle weakness, then you may need to be prepared at any time to support their airway. Make sure you have oxygen, and suction equipment close by. You might need to have an intubation cart nearby if the patient is experiencing difficulty with their respiratory muscles. Sometimes it can affect their oropharyngeal muscles, again, which is their ability to swallow. They can possibly aspirate. So that would be your class 4B patient who's experiencing these symptoms. And they might need support with breathing and with nutrition. So it's important that myasthenia gravis is something that can be controlled. However, it can lead to death related to a respiratory failure, so we need to make sure that we can be on the lookout for that and be able to support it and treat it appropriately. These are some of the signs and symptoms that a patient has secondary to myasthenia gravis. Usually it's an extreme fatigue is how the patient presents, and typically the most difficult thing to deal with for a patient with myasthenia gravis is the extreme fatigue. This patient shows the early stages where they feel fine in the morning, but often in the afternoon they become extremely fatigued because they have the proximal muscle weakness worsens with repetitive use. So throughout the day, the more you're using your muscles, the more tired they get. So in the afternoon, they'll often develop diplopia, which is blurred vision due to the ocular neuron weakness. They can get drooping eyelids, which is ptosis, and a weakness with their smile, which this is kind of representing here. And this is just a good picture here that shows the distribution of where it typically affects the muscles. So you can see only in 10% is it going to affect the thoracic muscles, but it's important to know that it can. But 95% does affect your facial muscles, so a lot of times they might end up in respiratory distress secondary to an aspiration. So here's kind of a little case study to look at. It can occur in an active 20-year-old female college student with clinical manifestations of myasthenia gravis. So let's talk about diagnosis, how this would be diagnosed. One thing I do want to mention is that myasthenia gravis can be associated with a thyroid function problem or a thymus gland problem, which is known as a thioma, which means an abnormal growth of the thymus gland. So oftentimes, especially in this 20-year-old female patient, they'll often check their thyroid gland and their thymus gland to determine if that is the cause of their myasthenia gravis symptoms. Especially in a 20-year-old female young person, the diagnosis may be delayed or missed due to the fact that the initial symptoms can be somewhat vague. And if the patient needs to see someone who knows enough about the signs and symptoms of myasthenia gravis to be able to pick up on it and suspect it. Other neurologic tests will be done, such as repetitive nerve stimulation, EMG, to help support the diagnosis of myasthenia gravis. And again, these are tests done again, we talked about EMG with Guillain-Barre as well. It's a recording electrode that's placed in the skeletal muscle, and the electrical activity of the skeletal muscle can be monitored. So that could be very helpful in supporting the diagnosis of myasthenia gravis. As far as definitive diagnosis, there is a test that's called the Tinslin test, and this is giving the patient medications. It's an anticholinesterase medication, and see if the patient responds to it. So if they're just experiencing maybe the drooping of their eyelids, the diplopia, the extreme weakness, and then we give them a dose of a medication used in treatment for myasthenia gravis and the patient responds to it, then we're going to call it myasthenia gravis. Tinslin is an anticholinesterase medication that what this medications do is increase levels of acetylcholine in the myoneural junction, so it helps to fix the problem that the patient is experiencing of not having enough acetylcholine. So tensilin is chosen in the diagnosis test for myasthenia gravis because it has a rapid onset and brief duration of action. So the patient should experience improvement in their symptoms really quickly after we give it. So that's why it is helpful in the diagnosis. Tensilin is used most often for testing because of the rapid onset and brief duration of action. This drug inhibits the breakdown of acetylcholine at the postsynaptic membrane, which increases the availability of acetylcholine for excitation of the postsynaptic receptors. In performing this test, the healthcare provider first they'll do like an EMG to estimate the strength of the cranial nerves and then inject the medications. The patients should have improvement in their symptoms within 30 to 60 seconds after the first dose. Most myasthenic patients show a marked improvement in muscle tone that lasts 4 to 5 minutes after being given this medication. The tensilin test can cause cardiac dysrhythmias and cardiac arrest. They rarely occur, but the patient or the nurse should be at the bedside along with the patient and the provider in order to monitor the patient for any signs of this, and have a medication called atropine sulfate, which is the antidote for tensilin. Have it there at the bedside in case the patient does experience a cardiac dysrhythmia and we need to give it. So just kind of write this so you remember this. The tensilin can cause cardiac problems. So the nurse and the provider need to make sure that we have atropine at the bedside as an antidote for the tensilin. So just kind of review like how this would make you feel, a 20-year-old college student, if you have these, are diagnosed with myasthenia gravis, someone who's experiencing severe fatigue in the afternoon, and symptoms such as that. How would that affect your life and being able to try to maintain your studies and maintain a social life and things like that? So it can be kind of devastating socially and psychosocially to the patient, so make sure that we identify this and get them the support they need. This is just a slide that summarizes myasthenia gravis. Again, it talks about an autoimmune destruction, and acetylcholine is the problem here, the decrease in the acetylcholine receptors. And the clinical manifestations is a weak, tired, typically affecting the muscles of the eyes. Diagnosis, the tensilin test is often used, EMG, and then we can also check for the antibodies in order to determine if it's an autoimmune cause. And remember, it also can be thought to be associated with a thymus gland problem or a thyroid gland problem, so we will make sure we rule that out first. Therapy is these anticholinesterase medications. Steroids, because remember that autoimmune, we can decrease that autoimmune response. Thymectomy, and then incidents that it is associated with a thymus gland tumor. We will discuss these treatments a little bit more in the next few slides. There are two groups of medications that are typically utilized in the treatment of myasthenia gravis. It is important to note that myasthenia gravis is one of the most treatable neurologic disorders. The classic presentation of myasthenia gravis is muscle weakness that increases when the patient is fatigued and limits his or her mobility and ability to participate in activities. So management for this is two different types of medications. The first one is the anticholinesterase or cholinergic drugs, also known as anti-myasthenic medications, which help to make the availability of acetylcholine more. And also therapeutic efforts for inducing that remission, such as that immunosuppressive medication, such as corticosteroids. Plasmapheresis can also be utilized because remember we can remove the antibodies that's causing the problem sort of like a dialysis type removal of particles in the blood. The anti-myasthenic medications, also the cholinesterase inhibitors, enhance neuromuscular impulse transmission by preventing the decrease of acetylcholine. This increases the response of the muscles to nerve impulses and improves muscle strength. Medications that fall under this category are mestinon and Reginol. The patient may have to do a day-to-day variation in the dosage depending on the patient's changing symptoms. So it's according to how weak they are, they might have to, or how stressed they are, they might have to increase their dose depending on what's going on in their life. These medications should be taken with small amount of food to help alleviate GI effects. A potential adverse effect of cholinesterase inhibitors is a cholinergic crisis. So there's 2 crises that can occur from these medications and from myasthenia gravis. And these are life-threatening, so we always need to be on a lookout for this. Myasthenia crisis is an exacerbation of the myasthenic symptoms caused by not enough anticholinesterase drugs. A cholinergic crisis is an acute exacerbation of muscle weakness caused by too many of these medications. So it's a kind of a balance, and it might be a little bit of a waiting game when the patient initially starts on these medications to find their appropriate dosage. There's a couple of tables in your book about key tips to give a patient regarding these medications. Helpful hints for teaching patients with myasthenia gravis about drug therapy. A lot of it is kind of wear a watch with an alarm to remind you to take your medicine. Plan strenuous activities when possible when the drug peaks. Keep a secure supply of drugs in your car at work. That way you have it with you in the event that you need a little extra dose. Check your healthcare provider before using any over-the-counter medications. Things like that. This is that Tinslin test that we already spoke about in the last few slides. And again, just remember that it can cause cardiac arrhythmias, so the nurse has to be on the lookout for that and have atropine on hand in the event that a patient has a cardiac arrhythmia. So these are those crises related to a patient who has myasthenia gravis. There are some tables in your book that kind of help you tell them apart. So we already talked about the Tinslin crisis. That's if they have an adverse effect to the Tinslin test. Cholinergic crisis is an acute exacerbation of muscle weakness caused by too many of the anticholinergic medications. In this event, do not give any more of the drugs while the patient is on a ventilator. Atropine, 1 milligram may be given, and remember, atropine is the antidote for too many of the anticholinergic medications. A myasthenic crisis is an exacerbation or worsening of the myasthenic symptoms caused by not enough of the anticholinesterase drugs. It's usually caused by some type of an infection. Increased muscle weakness leads to an overdose sometimes, so it's a kind of a happy medium that we have to find with a lot of these patients. In the event of a myasthenic crisis, the priority nursing management is to make sure that we monitor the airway and provide an adequate airway for the patient. We do not actually give the anticholinesterase medications in the event of a myasthenic crisis due to the fact that there's a respiratory compromise usually involved in this, and it's usually not effective for the first few days after a crisis. So drug therapy is not usually restarted right away. It's usually restarted gradually and at lower doses in this event. Sometimes it can be difficult to differentiate between a myasthenic crisis or a cholinergic crisis. Sometimes they'll do a little Tinslin test to kind of help determine which kind it is. if the patient has resolved symptoms and secondary to the injection of the tensilin, then they'll call it a myasthenic crisis. So sometimes a tensilin test is used to differentiate between a myasthenic crisis and a cholinergic crisis. So reviewing the management of a patient with myasthenia gravis, immunosuppression with those corticosteroids, methotrexate is one of those immunosuppressants that we've talked about in the past. This can help decrease that antibody formation. Remember, any kind of precautions and teaching that you need to teach a patient who's taking a corticosteroid applies for this as well. We've already talked about plasmapheresis. It's a method by which the antibodies are removed from the plasma to decrease the symptoms. Again, you'd have to monitor the site where they do the procedure. Make sure you kind of follow up, make sure they don't have any complications secondary to the plasmapheresis. Respiratory support. The patient with myasthenia gravis is at risk for developing difficulty with respiratory compromise. Not all patients have respiratory compromise, but ongoing assessment and maintenance of respiratory status is always as a high priority in a patient with myasthenia gravis. Self-care guidelines is making sure the patient has the ability to perform their ADLs, maximizing independence and making attempts at self-management successful. This helps the patients not only psychosocially, but to maintain their independence is a good confidence booster for a patient. Rest is critical because repetitive movement is what precipitates a crisis typically. Occupational and physical therapies can help with assistive devices, etc. They can also teach the family and patient energy conservation techniques. Weakness of the speech and facial muscles often results in slurred speech. So a speech pathologist can help the patient with this as well. Nutritional support is always important. If they have any kind of the effects on their muscles needed for chewing and swallowing, they could have difficulty getting proper intake. High-calorie snacks are often well tolerated. There's a good table in your book, Improving Nutrition in Patients with Myasthenia Gravis. It talks about assessing their gag reflex and ability to chew, frequent oral hygiene, collaborating with a dietitian, cutting food into small bites, observe the patient for choking, keep the head of the bed elevated during meals and 30 to 60 minutes after, monitor their intake, weigh them daily, consider thickening their liquids and things like that, and administer their medications as prescribed. The patient's inability to control their eye movement and possibly have a drooping of an eyelid can cause damage to their eye, so oftentimes we have to provide support with that. It might be giving them artificial tears to keep the corneas moist, a lubricant for their eyes, again, and sometimes a patch wearing over their eye can be assistance with this as well. Patients who have been identified as patients who have a thymus gland problem may need to have surgical removal of their thymus gland. That is in the area of their neck, so monitoring them post-procedure for any kind of airway obstruction would be important. Again, myasthenia gravis is a completely treatable disorder. It's important to help a patient maintain their independence and to teach them ways to prevent any exacerbations. They need to take their medications correctly. Home care management, we need to make sure they have good home support, and just make sure they're well educated about their drug regimen. Make sure that you explain that the drugs are usually taken before activities such as eating, participating in sports, or working. Stress the importance of maintaining therapeutic levels by taking the medications on time and as prescribed, and not missing or postponing doses. Inform the patient of the side effects of these medications and make sure they understand how to identify if they perhaps are getting a life-threatening situation such as a myasthenic crisis or a cholinergic crisis. This concludes this presentation for Nursing 150, Myasthenia Gravis, and Guillain-Barre Syndrome. The following slides are some questions to do review and assess your learning. I encourage that you answer them, and you can find the answers within the posted PowerPoint and additional resources.